Good afternoon to everyone present here with us today. This is Trion from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned Professor Dr. Ketan Mehta. Sir is MD Med, FCPS, FICP, FISC, FGSI, FDI, consultant physician, cardiopulmonologist, diabetologist, Mumbai, consultant at Health Harmony, Milan. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is hypertension guideline in diabetes. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Good evening, friends. So, today we are going to discuss something very interesting, and I must thank IJCP for having such an interesting topic, which is of utmost importance when we talk about the clinical practice, and that is hypertension guidelines in diabetic subset. You all would be seeing a number of patients of diabetes, and at the same time, you also would be seeing number of cases of hypertension. Now, today we are going to discuss about blood pressure management in a diabetic patient. So, because blood sugar management in diabetic patient, which is a subject by itself, but I'm sure you have heard a lot about it. Today, this combination, which we are going to see, and that is of utmost importance. I would begin with a quote from Sir Alvin Toffler, who states that the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. And that's where we are today because there are so many theories which we learned in the past has proven to be wrong now, and then so many theories which we never thought of are emerging out as the current recommendation. So let's look at this interesting topic. So we know that hypertension is one of the most important comorbidities of diabetes because we know that diabetes carries itself with lots of morbidities and mortality because of complications, and one of the known jugalbandi which we say in diabetic patient population is hypertension, and it is responsible for macrovascular as well as microvascular complications. So, when we talk about the macrovascular complications, these are atherosclerotic cardiovascular disease, peripheral arterial disease, and cerebrovascular disease like stroke. And when we talk about the microvascular complications, it is retinopathy, neuropathy, and nephropathy. So, what does it mean? That a diabetic patient, if has got associated hypertension, there is increased incidence and prevalence of microvascular as well as microvascular complications. Now, let's look at the Indian scenario. So, what we call this as the deadly duo in India. So, there is a high prevalence of hypertension in diabetes population, and this is as per the latest data which was published in JAPI, that the prevalence is 58%. So, it is a huge prevalence which we are talking about. Now, when we talk about this prevalence, the data which is there from RSSDI guidelines 2022, that there is this risk of hypertension in diabetic population is marked in the elderly population. And in India itself, an increase in coexistence of diabetes and hypertension is being reported. So patients with diabetes showed 1.5 to 2 times higher prevalence of hypertension than those without diabetes. So imagine having diabetes itself puts a subject at a higher chance of getting hypertension. So that is an interesting point which we have to keep it in mind. Now, I would be focusing about as I mentioned about the recent guidelines. So there are few guidelines which are of importance, and I would always like to talk about Make in India, Made in India. Because our beloved Prime Minister Sri Narendra Modi ji always stresses about the local applications, and then here we are got RSSDI guidelines which were published in 2022, that is Research Society for Study of Diabetes in India. And what does it recommend? So it recommends for office BP there are certain points which has to be kept in mind. you know we need to avoid something called as white coat hypertension, for which what are important is condition of the room, position of the patient, and device with which the blood pressure is measured. So condition means it has to be a quiet room with comfortable temperature, not very hot like the current situation, or it should not be a chilling AC which has been kept also. Before the measurement, the patient should avoid smoking, having a cup of tea or coffee, or empty their bladder. Now that's most important. They are waiting for a long time in the chamber with full bladder. That itself will cause false elevation of blood pressure. They should be remain seated and relaxed for 3 minutes is taken, and ideally before, during, and between the meals. So it should be done quietly. Don't push the patient to do anything. Just quietly but since slide it is not seen. Was this slide visible? Okay, sorry for the technical glitches. I was not knowing that my slides are not visible. Probably IJCP is facing some issues, so they are also, I can't hear what they are talking about. So, okay, anyway, nevertheless, uh, I was mentioning about recommendations for office BP, the condition in which the BP is taken. So it should be a quiet room with comfortable temperature. Not take coffee, tea, should not smoke, should not exercise for 30 minutes prior to that, should empty the bladder, remain seated and relax for 3 to 5 minutes. And neither patient nor staff should talk before, during, and between measurements. Position, it's position with arm resting on table, supported chair, legs uncrossed and feet flat on the floor. And the device, we know that mercury thermometers are no more available or will not be available. Electronic oscillometric upper arm cuff device should be used. Checking about the cuff size, the size according to individuals' arm circumference should be used. So smaller cuff can overestimate, larger cuff can underestimate the blood pressure. So it should be as per the size or arm size of the patient. And for manual auscultatory device, the inflatable bladder cuff must cover 75% to 100% of the individual's arm circumference. Now, protocol wise, at each visit, take three measurements with 1 minute between them and calculate the average of the last two measurements. Okay. If BP of first reading is less than 130 by 85 millimeters, no further measurement is required, and blood pressure of 2 to 3 office visits more than or equal to 140 hypertension. So one single reading of blood pressure more than 140/90, do not label it as a hypertension. That is a point needs to be kept in mind. Now, the management of hypertension in patients with diabetes lowers the risk of ASCVD. So it's most important. If you want to reduce atherosclerotic cardiovascular disease events, is not just control of blood sugar but control of blood pressure also. Now look at these amazing numbers. With every 10 millimeters mercury decrease in systolic BP, the risk of complications of diabetes is reduced by 12%, and the associated mortality is reduced by 15%. So you are controlling the blood pressure and you are reducing diabetes related complications. Isn't it amazing? And that is where the power is, that we must control the blood pressure. So now let's look at the management aspect also. As for all the other recommendations, still dietary and lifestyle recommendations also forms part and parcel of any recommendation, especially for blood pressure control in diabetes. So what is the target value? Now that is 30 millimeters of mercury must be achieved in patients with coexisting diabetes and hypertension through a combination of dietary and lifestyle interventions. So here I would put it lifestyle intervention, which comprises of ahar, vyohar, vichar, and achar. All four put together can give you a conglomeration of lifestyle changes. So ahar, which is the most important factor, but then there are other recommendations also. So there has to be a nutrition education which given to each and every individual at the first visit when they are detected to be hypertensive, physical activity, and a brisk walking. So now that is which is very important, which can be just a bare minimum form of physical activity, and whatever the person can do it 50 to 6 up to 50 to 60 minutes 3 to 4 times in a week is also a very effective way in managing the hypertension. Now talking about the dietary recommendation, so I would definitely would like to give more stress on this, and we Indians have got in sodium content when we eat or whatever we consume. Remember one thing, no more than 1500 milligram of sodium per day in this subset. So 1.5 grams, which will be just a bare minimum sodium. Avoid packaged, mixed, canned soups, broths. Use of fresh salted snacks foods, kurkure, namkeens, nachos, all these are which are accessories. So remember one thing, when you have to tell your patients with hypertension, if you have to restrict the salt, you are going to tell them that you can have it in your routine meals, that is in sabji and dal, where they cannot have it without salt because it will be absolutely bland. I am sure they will have a nauseating feeling. But all accessories, achar, chutney, papad, pickles, all these things needs to be curtailed also. Coming to pharmacologic therapy, I would like to talk about certain groups and their relevance also. Now, of which most important are AC inhibitors. I am sure you know various therapies for diabetes, various classes. Now, you really have a basket of drugs. AC inhibitors, that is angiotensin converting microvascular and macrovascular complications of that. A drug will not only reduce your blood pressure but will have a preventive effect for complications in diabetes, nothing like it. So AC inhibitors delay the progression of diabetic kidney disease, and therefore they form as the most important line of therapy when it comes to hypertension management in diabetic population. AC inhibitors, which are there in this chart, beautifully summarizes various AC inhibitors. So you have compounds like enalapril, lisinopril, benazepril, captopril, fosinopril, quinapril, and benzopril. And this chart has comprising very and I want you to highlight on certain points. Look at this FDA indication. All AC inhibitors are not approved for each and every indication. Like there are few AC inhibitors approved for CHF. You are indicated for dysfunction. Few have been, but remember, each and every AC inhibitor has been approved by FDA for use in hypertension. Now that is the beauty of this molecule in hypertension. Now, you should also be knowing the maximum dosage of each class of drug, and it has been said that the maximum beneficial effect of the drug is achieved when you reach the highest possible dose. So, for enalapril, for example, it is said that it has a maximum example, 20 milligram twice a day, lisinopril 80 milligram once a day, penem 50 milligram 3 times a day, fosinopril 80 milligram once a day, quinap milligram once a day, and ramipril 20 milligram once a day. So you can imagine we are really underusing the dosage of AC inhibitors. Talking about elimination. Now look at this. There are certain points you should be aware about. For example, enalapril has got a 94% renal elimination, whereas if you talk about ramipril has got a 60% renal and 40% feces. So if you have to use with even a mild renal insufficiency, ramipril would be a better option than enalapril because it has got a dual mode of elimination. So these are certain you should be keeping in mind while selecting the molecule. Now let's look about ARB or what we call angiotensin receptor blocker. So in a randomized controlled trial of patients with type 2 diabetes and early nephropathy, telmisartan in preventing reduction in GFR. And the renoprotective effects of inhibitors and ARBs are the independent of blood pressure lowering properties. That's very important point. So it is not that it has a beneficial effect by lowering the BP, independent of BP lowering effect. There is a renoprotective effect which has been seen with two classes of drugs. Fully summarizes the pharmacologic characteristics of various ARVs. And you know the drugs which you are commonly using are losartan, candesartan, Iprosartan, irbesartan, telbisartan, valsartan, olmesartan, azilsartan. So it's a certain group of drugs. We know all of them have got a different half-life, different bioavailability, route of elimination also would be there. So here one thing you will have to keep it in mind, like drugs like losartan has got interaction with referin and conazole, so that needs to be taken care of. And the drug like telmisartan has got a interaction with digoxin. So these are few points you have to keep it in mind. Now let's look about diuretic. Now I'm sure you have heard about the SHAPE trial, that is systolic hypertension in the elderly program, where chlorthalidone reduced the cardiovascular and cerebrovascular events in a patients with type 2 diabetes and isolated systolic hypertension. And this was a very beautiful study where CTD or chlorthalidone has shown the benefits which are shown. And over a period of time, we know that drugs like chlorthalidone have been used more over hydrochlorothiazides, which has got a beneficial effect. So chlorthalidone has a longer duration of action and a longer half-life than hydrochlorothiazide. It may be a more potent than hydrochlorothiazide in lowering BP, but it also may be associated with more metabolic adverse effects like the most hypertension guidelines recommend thiazide diuretics as one of the classes of agents that can be used either as initial antihypertensive drug therapy or as a part of combination. So you have a choice in that. So much conflict and the noise level, that is beta blockers. Now, if you remember, the UKPDS 39 had shown no difference in the rates of minor or major hypoglycemic episodes in a patients treated with atenolol compared to those treated with captopril. So you remember we are all worried about that hypoglycemia unawareness which would be created by beta blockers, like what we used to use is past. Now that was propranolol, but now you have a good classes of drugs in beta blockers. For example, carvedilol is less likely than traditional beta blockers to worsen insulin sensitivity in patients with diabetes. you have the and which will have an effect. So remember, beta blockers are not all equal members of one family of drugs. Suppose in one family three sons are there, not necessarily all three are will have a similar characteristics. One may be really good, second may be average, and third may be bad. So similarly, when we talk about here beta blockers, look at carvedilol, which causes vasodilatation via inhibition of sympathetic alpha 1 receptors, and nebivolol causes nitric oxide derived vasodilatation. So every molecule in beta blockers also has a demerits of individual compound. Now look at the calcium channel blockers. Dihydropyridine calcium channel blockers, that are CCBs, reduce the cardiovascular events in patients with diabetes and hypertension, and hence these are also used for managing hypertension in diabetes. So there are lot many in a diabetic population, and there are lot many out of it. So there are various classes of drugs. So what does the guidelines say? What is the guideline recommendations? Now, look at this summary of the various targets given by different societies for management of hypertension and diabetes. And you take it any guidelines, UK, NICE, CHAP, WHO, IDF, JSH, IGH, ESC, ESH, ADA, ASH, ISH. The guidelines may be telling different, but the target now what has come, which is more often is one thing. In a diabetic population, hypertension, when you are targeting, target should be at 130/80. And look at the first class or worst drug class. It is ACE inhibitors or ARBs. So that should be the first line of drugs. So the recommended BP target for individuals with diabetes should be less than 130/80 millimeters of mercury. And there is a it can be less than 140/80 in elderly patients. So that is where there is a caveat, some laxity is there. That is as per RSSDI recommendation. Overall, it should be less than 130/80 millimeters of mercury. Now, look at the treatment strategies in diabetes. So, drug treatment strategies in patients with type 2 diabetes should be the same as for patients without diabetes, but the primary aim to lower the BP below 130/80 millimeters of mercury, and this is class 1A recommendation. Another point that BP control is difficult in diabetes and combination treatment is almost always necessary. Now, doesn't is class 1A, but is class 1B because it is almost always. So it is not for 100% patients. You need to take a call from individual basis, but most of the patients will require a combination therapy. Now, next development, look at that. You will be amazed, which has come in 2023, that SGLT2 agents in type 2 diabetes, and these agents have a BP lowering effect. So we know that it is an anti-diabetic medication, but it also has a BP lowering indications. Now, what has come is if the patient has got diabetes plus hypertension, you please use SGLT2 inhibitors because it will have an additional BP lowering effect, and it will have a cardioprotective and nephroprotective recommendation. Is class 1A. What a strong recommendation it is having. Class 1A recommendation is the known steroid can be used because of its with diabetic CKD and moderate to severe albuminuria because fenrinone has a BP lowering effect. So, hypertension, diabetes, CKD. And if you're healthy, you can go for fenrinone, which is a class 1A recommendation. Now I will take you to American Association of Clinical Endocrinologists 2023 hypertension treatment algorithm. What does it say? That, as we mentioned, the goal should be less than 130 by 80. You start with lifestyle sorry, intervention. Next, you need to go for starting with ARB or ACE inhibitor. Now, here they are recommending ARB more than AC inhibitor. Then you need to titrate the medication dose or add on therapy every 2 to 3 months to reach the goal. Next, they are recommending adding thiazide or calcium channel blockers and then combine blockers or beta 1 selective blocker or mineralocorticoid receptor antagonist. And finally, the other dilators like hydrazine, which can be used. So it is beautifully summarized there. And I will take you to the latest American Diabetic Association 2024 recommendation. What recommendation for the treatment of confirmed hypertension? So they are divided into two categories: 130 by 80, but less than 140, along with lifestyle management. But 50 by 90 millimeters of mercury. Besides lifestyle management, directly start two agents. So do not wait for the to show the full effect, wait for a few months and then add because you started two agents. Now this is the new thing which has come up and you must adopt in your clinical practice. One agent or two agent. Now look at it. You need to check it whether the presence or absence of albuminuria or artery disease. Right. AC inhibitor, ARB, CCB, diuretic. Depending on the BP reading, you will start with one agent or two agent. But if there is a presence of albuminuria or if there is a presence of coronary artery disease, you must start with AC inhibitor or ARB. And if it is more than 150/90, along with AC inhibitor or ARB, you will add CCB or diuretic. So this is the beautiful initial recommendation, very excellent results in your clinical practice. Okay, we'll go to that further. Then you need to assess the BP control and therapy or go on adding another class of drugs, increasing dosage. You need to look at the adverse event and go on assessing the blood pressure. That is most important. Now, this is again I have shown here summary of BP goals and initial physically combining. Again, we are talking about the latest one, less than 130, 80 millimeters of mercury. Okay, now few points now I would come to our own again RSSDI recommendation for the management of hypertension in patients with diabetes. Why I am bringing it because this is pertinent to Indian subset of patients. Does it say that ARBs either alone or in combination with CCBs can be used for BP control in diabetic patients, which is grade A. So that means if you combine our previous recommendation somebody who has a BP more than 150/90, you're going to use two classes of drugs, and that for them, ARB plus CCB would be the best combination. So, combination therapy of hypertensive patients for a better BP, better patient adherence. Clinical evidence suggests that single pill combination, what we call fixed dose combination, SPC, containing two or more antihypertensive agents offers potential advantage over free drug combination. So, if you have to give a combination, why not give fixed dose combinations? You will reduce pill burden and bill burden. That would be definitely useful. Now, this is as per the RSSDI guideline, management of hypertension, patient with diabetes. So you have four classes of drugs: ARBs, ACE inhibitor, diuretics, because they are not recommending beta blocker as the first line agent. Of course, that would come in a compelling indication. Now, of ARBs, the preferred one are telmisartan and azilsartan. Among CCBs, it is cilnidipine and amlodipine. And if you have to combine, the preferred combination is a first line agent in combination therapy is telmisartan plus cilnidipine, which is used in a patient with existing cardiovascular disease, CKD, or other complications also. So this is from as per the RS. I would end with giving you a clue about some future treatment molecules. So there are several novel drugs such as peptide and non-peptide based therapeutic agents that may function as a RAS inhibitors, have been emerging to manage hypertension in diabetic patients. We know that RAS blockade forms the mainstay of therapy. And for personalized treatment of hypertension in a patient with diabetes, the use of artificial intelligence technologies, which are going to come in a big way. You will have a gene sequencing mechanism, genomics, transcriptomics, proteomics, and metabolomics, which will come in a big way and it will individualize a treatment. So we are going to see different future altogether. So ladies and gentlemen, to summarize, patients with diabetes should achieve a target BP of less than 130 by 80 millimeters of mercury. It should be hammered not only in your mind, but you need to hammer it in your patient's mind. The use of ACE inhibitors, ARB, may slow progression to kidney failure and cardiovascular mortality, and these agents are the preferred therapy for managing coexisting diabetes and hypertension. When combined with ACE inhibitors or ARBs, beta blockers and calcium channel blockers also have beneficial effects in managing hypertension in patient with diabetes. And multiple antihypertensive effects also. Remember a beautiful quote from Sir William Osler that the good physician treats the disease, the great physician treats the patient who has the disease. And you all are a great physician. I'm sure you will use wisely and rightly the right therapy. And I would end with a beautiful quote from Sir William Osler that what states is what we receive is information, what we preserve is knowledge, what we use is intelligence. But what, when, and how we use it is our wisdom. And we used to definitely have a that will be helpful to all our patients. Thank you so much for your patient hearing, and we would be happy to take up the questions if there are any.
Yes, sir, we do have some question if you like to take that up. So, sir, the first question is, how do you
Okay,
incorporate patient
so I
education?
can see few
Yes, sir.
questions. Question one: how do you incorporate making into hypertension management for diabetic patient? Okay, so simple patient education should form a part of your team. I know it may not be possible to have a counseling at every visit. You need to have
Sir, you're again on mute, sir. Hello? Yes, sir, you can start now. Thank you, sir. Uh, I think there is some issue from your end in the network, sir. Yes, am I audible to you now? Hello? So I hope that I'm audible to you.
Happy
Sir, you're again on mute.
connected today. Anyway,
Uh, yes, sir, you were saying something?
I don't know what's happening.
So due to some network issue from your end, I think there is
Is the
some
IJCP
glitches happening.
way, nevertheless. So we need to take care of it. I think probably indirectly it's giving a hint that it is time to wind up. Okay, so with these words, I would like to thank IJCP and would tell managing hypertension and diabetes is a really not only challenge complications of diabetes.
Thank you. Thank you so much.